Question 1. Examination of the data shows a 65-year-old male admitted to the intensive care unit with severe sepsis and acute respiratory distress syndrome ARDS. Arterial blood gas analysis reveals a partial pressure of oxygen of 55 mmHg on a fraction of inspired oxygen of 0.8 and a positive end expiratory pressure of 10 cmH2O with a respiratory rate of 24 breaths per minute and a partial pressure of carbon dioxide of 38 mmHg. Chest X-ray demonstrates diffuse bilateral opacities. The patient is hemodynamically stable but appears to be in significant respiratory distress, with accessory muscle use evident. Considering the principles of gas exchange, ventilation-perfusion matching, and lung mechanics in ARDS, which of the following ventilatory strategies would be most appropriate to initiate? Option A. Administer neuromuscular blockade and sedation to fully unload the respiratory muscles and reduce oxygen consumption while maintaining current ventilatory settings. Option B. Initiate inverse ratio ventilation with a high inspiratory to expiratory ratio to maximize alveolar recruitment and improve oxygenation. Option C. Increase positive end expiratory pressure, PEEP, to 18 cmH2O and maintain current tidal volume and respiratory rate, aiming to improve oxygenation by recruiting alveoli. Option D. Reduce tidal volume to 4 ml/kg ideal body weight and increase respiratory rate to 30 breaths per minute, while maintaining current PEEP and FiO2 to reduce driving pressure and improve ventilation. Correct answer is C. Increase positive end expiratory pressure, PEEP, to 18 cmH2O and maintain current tidal volume and respiratory rate, aiming to improve oxygenation by recruiting alveoli. Explanation. This scenario is professionally challenging because it requires the specialist to integrate complex physiological understanding with the practical application of evidence-based interventions within the strict confines of the Adult Critical Care Specialist (ACCS) regulatory framework. The core challenge lies in accurately assessing the patient's respiratory status, identifying the underlying pathophysiology, and selecting the most appropriate ventilatory strategy that aligns with established guidelines and patient safety principles, all while considering the potential for rapid deterioration. The correct approach involves a systematic evaluation of the patient's gas exchange, mechanics of breathing, and overall respiratory drive. This includes assessing oxygenation and ventilation, identifying the presence and severity of shunt or dead space, and understanding the impact of critical illness on pulmonary vascular resistance and work of breathing. The specialist must then apply this understanding to select a ventilatory mode and settings that optimize gas exchange, minimize lung injury, e.g., ventilator-induced lung injury, and support the patient's physiological needs, adhering to ACCS competency standards and best practice guidelines for mechanical ventilation in critical illness. This ensures patient safety and promotes recovery by addressing the root causes of respiratory failure. An incorrect approach would be to implement a ventilatory strategy based on anecdotal evidence or a superficial understanding of the patient's condition without a thorough physiological assessment. For instance, simply increasing the fraction of inspired oxygen, FiO2, without addressing the underlying ventilation-perfusion mismatch or shunt would be a failure to apply appropriate physiological principles and could lead to oxygen toxicity or mask worsening hypoxemia. Similarly, applying high positive end expiratory pressure, PEEP, without considering its potential to impair venous return or increase intrinsic PEEP in patients with airflow obstruction would be a deviation from best practice and could be detrimental. Failing to consider the patient's work of breathing and attempting to fully unload the respiratory muscles without appropriate assessment of their capacity could also lead to prolonged ventilator dependence or muscle deconditioning. These approaches demonstrate a lack of deep analytical understanding of respiratory physiology in critical illness and a failure to adhere to the rigorous standards expected of an ACCS. The professional decision-making process for similar situations should involve a structured approach. 1. Comprehensive physiological assessment, AB, hemodynamics, mechanics, imaging. 2. Identification of the primary pathophysiological derangements, e.g., ARDS, pneumonia, COPD exacerbation. 3. Consideration of the patient's overall clinical status and goals of care. 4. Selection of ventilatory strategy based on evidence-based guidelines and physiological principles, prioritizing lung protection and optimization of gas exchange. 5. Continuous reassessment and adjustment of ventilatory parameters based on ongoing monitoring and patient response. Question 2. Assessment of a 65-year-old male admitted to the intensive care unit with acute onset of severe dyspnea, hypoxemia, PaO2/FiO2 ratio of 90 mmHg on 100% FiO2 via non-rebreather mask, and bilateral pulmonary infiltrates on chest X-ray, in the absence of overt signs of left heart failure, requires a systematic approach to management. Which of the following diagnostic and therapeutic strategies best reflects the expected standard of care for an adult critical care specialist ACCS in this scenario? Option A. Administer intravenous diuretics and vasodilators to manage presumed cardiogenic pulmonary edema, pending further investigation. Option B. Confirm diagnosis of acute respiratory distress syndrome ARDS, based on established criteria, and initiate lung protective mechanical ventilation with low tidal volumes and appropriate positive end expiratory pressure (PEEP). Option C. Proceed directly to empiric treatment for bacterial pneumonia with broad-spectrum antibiotics and monitor oxygen saturation. Option D. Initiate high-flow nasal cannula oxygen therapy with aggressive fluid resuscitation to improve oxygenation and hemodynamics. The correct answer is D. Initiate high-flow nasal cannula oxygen therapy with aggressive fluid resuscitation to improve oxygenation and hemodynamics. Explanation: this scenario presents a professional challenge due to the critical nature of ARDS and the need for timely, evidence-based interventions. The complexity lies in differentiating ARDS from other causes of acute respiratory failure and initiating appropriate management strategies that align with current best practices and regulatory guidelines for critical care. Careful judgment is required to avoid delays in diagnosis and treatment, which can significantly impact patient outcomes. The correct approach involves a comprehensive assessment of the patient's clinical presentation, including oxygenation status, underlying causes, and exclusion of alternative diagnoses. This aligns with the ACCS framework, which emphasizes a systematic and evidence-based approach to managing critically ill adults. Specifically, the focus on identifying hypoxemia refractory to conventional oxygen therapy, the presence of bilateral infiltrates on imaging, and the absence of overt left atrial hypertension are key diagnostic criteria for ARDS. Initiating lung protective ventilation strategies, such as low tidal volumes and appropriate PEEP, is a cornerstone of ARDS management, directly supported by established critical care guidelines and regulatory expectations for specialist practice. This approach prioritizes patient safety and optimal physiological support, reflecting the ethical duty of care and professional accountability expected of an ACCS. An incorrect approach would be to solely focus on increasing FiO2 without addressing the underlying lung injury and implementing lung protective ventilation. This fails to recognize the specific pathophysiology of ARDS, where alveolar capillary membrane damage leads to non-cardiogenic pulmonary edema and impaired gas exchange. Such an approach risks volatrauma and barotrauma from excessive pressures, potentially worsening lung injury and patient outcomes, and contravenes established best practice guidelines. Another incorrect approach would be to prematurely assume a cardiogenic cause for pulmonary edema and initiate aggressive diuresis without a thorough evaluation for ARDS. While cardiogenic pulmonary edema can present with similar symptoms, ARDS has distinct underlying mechanisms and requires different management. Failing to differentiate can lead to inappropriate treatment, potentially causing hemodynamic instability or delaying definitive ARDS management. This deviates from the ACCS requirement for accurate diagnosis and targeted therapy. A further incorrect approach would be to delay mechanical ventilation until the patient is in extremis. ARDS requires prompt initiation of lung protective ventilation to mitigate further lung injury. Delaying this intervention can lead to progressive hypoxemia, increased work of breathing, and a higher risk of mortality. This demonstrates a failure to adhere to evidence-based protocols for managing acute respiratory failure in the context of ARDS. Professional reasoning in such situations involves a structured approach. First, rapidly assess the patient's airway, breathing, and circulation. Second, gather a focused history and perform a physical examination to identify potential causes of acute respiratory failure. Third, utilize diagnostic tools such as arterial blood gases, chest imaging, and echocardiography to confirm the diagnosis and differentiate between various etiologies. Fourth, Consult relevant clinical guidelines and evidence-based protocols for ARDS management. Finally, implement a tailored treatment plan, including lung-protective ventilation, appropriate fluid management, and supportive care, while continuously reassessing the patient's response. Question 3. Which approach would be most appropriate for initiating the weaning process in a hemodynamically stable adult patient who has met the initial criteria for readiness to wean from mechanical ventilation, demonstrating adequate respiratory drive and oxygenation on a PEEP of 5 cm H2O and FiO2 of 0? 4. Option A. Immediately extubate the patient without a formal SBT, assuming readiness based on initial criteria. Option B. Initiate a spontaneous breathing trial (SBT) with pressure support ventilation at a level of 8 cm H2O and a PEEP of 5 cm H2O. Option C. Increase the tidal volume and respiratory rate to a higher setting to strengthen the patient's respiratory muscles before attempting weaning. Option D. Transition the patient to continuous positive airway pressure (CPAP) alone without any pressure support. The correct answer is B. Initiate a spontaneous breathing trial (SBT) with pressure support ventilation at a level of 8 cm H2O and a PEEP of 5 cm H2O. Explanation: this scenario is professionally challenging because it requires the critical care specialist to balance immediate patient needs with long-term recovery goals, all while adhering to established protocols for mechanical ventilation and weaning. The specialist must consider the patient's physiological status, the potential for ventilator-associated complications, and the ethical imperative to liberate the patient from mechanical support as soon as safely possible. Careful judgment is required to select the most appropriate weaning strategy that minimizes risk and optimizes the patient's chances of successful extubation. The correct approach involves a systematic, evidence-based assessment of the patient's readiness for weaning, utilizing validated criteria, and a gradual reduction in ventilatory support. This aligns with professional guidelines and ethical principles that prioritize patient autonomy and well-being by avoiding prolonged mechanical ventilation when unnecessary. Regulatory frameworks for critical care emphasize patient safety and the timely transition to spontaneous breathing, thereby reducing the risk of ventilator-associated pneumonia, VAP, volatrauma, and barotrauma. An incorrect approach that immediately increases ventilator support without a thorough assessment fails to adhere to the principle of minimizing iatrogenic harm. This could lead to prolonged intubation, increasing the risk of VAP and other complications, and potentially delaying recovery. Another incorrect approach that involves abrupt discontinuation of support without adequate physiological preparation could precipitate respiratory failure, requiring reintubation and further compromising the patient's condition. This demonstrates a failure to follow established weaning protocols and a disregard for the patient's physiological reserve. A third incorrect approach that focuses solely on patient comfort without considering the underlying physiological need for ventilatory support might inadvertently prolong dependence on the ventilator, hindering the weaning process and potentially masking underlying issues. Professional reasoning in such situations involves a structured approach. First, assess the patient's readiness for weaning using established criteria e.g. spontaneous breathing trial tolerance, adequate respiratory drive, hemodynamic stability. Second, select an appropriate weaning mode or strategy based on the patient's condition and the identified readiness. Third, continuously monitor the patient for signs of intolerance or distress during the weaning process, and be prepared to adjust support or abort the weaning attempt if necessary. Finally, document the rationale for the chosen approach and the patient's response, ensuring continuity of care and adherence to best practices. Question 4. Implementation of a pharmacological strategy for acute bronchospasm in an adult critical care patient with a history of asthma and concurrent use of a beta blocker for hypertension requires careful consideration of drug selection and administration. Which of the following approaches best aligns with current UK ACCS guidelines and principles of safe medication practice? Option A. Prescribe a non-selective beta blocker to manage the patient's hypertension. Option B. Initiate a long-acting beta agonist, LABA, for sustained bronchodilation. Option C. Administer a short-acting beta agonist, SABA, via metered-dose inhaler with a spacer device. Option D. Administer a systemic corticosteroid as the primary intervention for bronchospasm. Correct answer is C. Administer a short-acting beta agonist, SABA, via metered-dose inhaler with a spacer device. Explanation: scenario analysis. This scenario is professionally challenging because it requires the ACCS to balance the immediate need for effective bronchodilation with the potential for adverse effects and drug interactions in a critically ill patient. The patient's underlying conditions and concurrent medications necessitate a nuanced approach to drug selection and administration, demanding a thorough understanding of pharmacodynamics and pharmacokinetics in the context of critical illness. Ensuring patient safety while optimizing therapeutic outcomes is paramount. Correct approach analysis. The correct approach involves selecting a short-acting beta agonist, SABA, such as salbutamol, administered via a metered-dose inhaler, MDI, with a spacer device or nebulizer, based on current UK guidelines for acute asthma exacerbations and COPD management in critical care. This approach is justified by its rapid onset of action, directly targeting beta-2 adrenergic receptors in the bronchial smooth muscle to promote bronchodilation. The choice of administration route, MDI with spacer or nebulizer, is crucial for efficient drug delivery to the lungs, minimizing systemic absorption and associated side effects. UK regulatory frameworks, such as those outlined by the National Institute for Health and Care Excellence (NICE), and professional bodies like the Faculty of Intensive Care Medicine, emphasize evidence-based practice and patient safety, supporting the use of SABA as first-line treatment for bronchospasm in critical care. The administration technique aims to maximize lung deposition and minimize oropharyngeal deposition, thereby enhancing efficacy and reducing systemic adverse events. Incorrect approaches analysis. Administering a long-acting beta agonist, LABA, as the initial bronchodilator would be an incorrect approach. LABA have a slower onset of action and are primarily used for maintenance therapy, not for the acute relief of bronchospasm in a critically ill patient. Relying on a LABA in this situation would delay effective bronchodilation, potentially worsening hypoxia and respiratory distress, which contravenes the principle of prompt and effective treatment mandated by critical care standards. Choosing a corticosteroid as the sole initial bronchodilator is also incorrect. While corticosteroids are essential in managing the inflammatory component of bronchospasm, their onset of action is delayed hours to days, making them ineffective for immediate bronchodilation. Their administration should be concurrent with or shortly after bronchodilators, not as a replacement. Failure to provide immediate bronchodilation would be a breach of duty of care. Administering a non-selective beta blocker would be a critically incorrect approach. Beta blockers, particularly non-selective ones, can cause bronchoconstriction by blocking beta-2 receptors, thereby exacerbating the patient's respiratory distress. This directly contradicts the therapeutic goal of bronchodilation and would pose a significant risk of harm, violating fundamental principles of patient safety and drug administration. Professional reasoning. Professionals should approach such scenarios by first assessing the patient's immediate physiological needs and the underlying cause of the respiratory distress. This involves a rapid but thorough evaluation of vital signs, respiratory status, and relevant medical history. Next, they must consult current evidence-based guidelines and protocols relevant to the specific critical care setting, in this case, UK ACCS standards. The selection of medication should be based on its pharmacological profile, including onset of action, mechanism of action, and potential for adverse effects and interaction, always prioritizing patient safety and efficacy. The chosen route and method of administration must be optimized for the critically ill patient. Finally, continuous monitoring of the patient's response to treatment and prompt adjustment of the therapeutic plan are essential components of professional practice. Question 5. The monitoring system demonstrates a progressive increase in peak inspiratory pressure, PIP, and plateau pressure, PPLAT, over the last hour, accompanied by a decrease in delivered tidal volume, VT, and a declining SpO2 despite an increase in the fraction of inspired oxygen, FiO2, to 0. 6. The patient remains sedated and paralyzed. What is the most appropriate initial step in managing this patient? Option A. Perform a thorough physical assessment of the patient's chest and airway, and systematically review ventilator parameters and patient factors for potential causes of increased airway resistance or decreased lung compliance. Option B. Increase the PEEP to improve oxygenation. Option C. Immediately increase the FiO2 to 1.0 and administer a bronchodilator. Option D. Decrease the respiratory rate to allow for longer expiratory times. Correct answer is A. Perform a thorough physical assessment of the patient's chest and airway, and systematically review ventilator parameters and patient factors for potential causes of increased airway resistance or decreased lung compliance. Explanation: this scenario presents a common yet critical challenge in adult critical care, interpreting complex physiological data and responding appropriately to potential deterioration. The professional challenge lies in synthesizing multiple data points, recognizing subtle trends, and making timely, evidence-based decisions under pressure, all while adhering to established clinical protocols and ethical obligations. The need for careful judgment is paramount, as misinterpretation or delayed intervention can have severe consequences for patient outcomes. The correct approach involves a systematic assessment of the provided data, correlating the observed changes with the patient's underlying condition and treatment plan. It requires a thorough understanding of respiratory mechanics, gas exchange principles, and the potential impact of various interventions. Specifically, recognizing the interplay between increased peak inspiratory pressure, plateau pressure, and decreased tidal volume, while simultaneously observing a rising fraction of inspired oxygen requirement and declining SpO2, points towards a worsening ventilatory or gas exchange issue, likely related to increased airway resistance or decreased lung compliance. The correct response would be to initiate a structured troubleshooting process, starting with a physical assessment, and then systematically evaluating ventilator settings and patient factors, guided by established critical care guidelines and institutional protocols. This aligns with the ACCS syllabus's emphasis on problem-solving and evidence-based practice, ensuring patient safety and optimal care. An incorrect approach would be to solely focus on one isolated parameter without considering the broader clinical picture. For instance, simply increasing the fraction of inspired oxygen without investigating the underlying cause of the declining SpO2 might mask a worsening problem, leading to delayed or inappropriate interventions. Another incorrect approach would be to immediately make drastic changes to ventilator settings without a systematic assessment, potentially exacerbating the patient's condition or causing new complications. Failing to perform a physical assessment to identify potential causes like bronchospasm, secretions, or pneumothorax would also be a significant failure, as clinical signs and symptoms are crucial in guiding diagnostic and therapeutic decisions. These incorrect approaches fail to uphold the professional responsibility to provide comprehensive and evidence-based care, potentially violating ethical principles of beneficence and non-maleficence. The professional decision-making process in such situation should involve a structured approach. 1. Recognize and validate the abnormal findings. 2. Gather all relevant patient data, including vital signs, ventilator parameters, and recent clinical events. 3. Formulate a differential diagnosis for the observed changes. 4. Prioritize interventions based on the most likely and life-threatening causes. 5. Implement interventions systematically, monitoring their effectiveness. 6. Document all findings, interventions, and patient responses. This systematic process ensures that decisions are not reactive but are informed, deliberate, and patient-centered, adhering to the highest standards of critical care practice. Question 6. During the evaluation of a patient admitted with severe traumatic brain injury, TBI, and a baseline Glasgow Coma Scale, GCS of 7, you observe a sudden decrease in pupillary light reflex bilaterally and a further decline in motor response. The intracranial pressure ICE monitor, previously stable, now shows a trending increase. Which of the following represents the most appropriate immediate management approach? Option A. Increase the sedation and paralysis regimen to reduce metabolic demand and allow for more stable ICP monitoring. Option B. Immediately notify the intensivist and neurosurgical team, prepare for osmotic therapy, and consider urgent repeat CT imaging. Option C. Continue to monitor the patient closely, documenting the changes, and wait for further significant deterioration before escalating care. Option D. Administer a bolus of intravenous fluid to improve cerebral perfusion, and then reassess the neurological status. The correct answer is B. Immediately notify the intensivist and neurosurgical team, prepare for osmotic therapy, and consider urgent repeat CT imaging. Explanation: scenario analysis. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient with a known neurological insult, specifically a traumatic brain injury, TBI. The challenge lies in the dynamic nature of intracranial pressure ICE and the potential for rapid neurological decline, requiring immediate and decisive action based on evolving clinical data and established protocols. The pressure to act quickly while ensuring patient safety and adhering to best practices, particularly concerning invasive monitoring and therapeutic interventions, is significant. The ethical imperative to provide timely and effective care, while minimizing iatrogenic harm, is paramount. Correct approach analysis. The correct approach involves a systematic and evidence-based response to the signs of increased ICP. This includes immediate escalation of care, which entails notifying the intensivist and neurosurgical team, and preparing for potential interventions such as osmotic therapy and further diagnostic imaging. This approach is justified by the ACCS regulatory framework and guidelines, which emphasize prompt recognition and management of critical neurological deterioration. The principle of beneficence dictates that the patient receives timely and appropriate interventions to prevent further neurological damage. Adherence to established protocols for ICP management, as outlined in critical care guidelines, ensures that interventions are evidence-based and aimed at optimizing patient outcomes. Incorrect approaches analysis. One incorrect approach involves delaying escalation of care and relying solely on non-invasive measures while observing for further changes. This fails to acknowledge the urgency of the situation and the potential for irreversible neurological damage if ICP is not managed promptly. Ethically, this could be considered a breach of the duty of care, as it deviates from the expected standard of practice for a patient with a known TBI and signs of increased ICP. Another incorrect approach is to immediately initiate aggressive interventions without a clear clinical indication or a comprehensive assessment, such as administering high-dose osmotic therapy without confirming the presence of significant ICP elevation or considering contraindications. This risks iatrogenic complications and may not be the most appropriate first step, potentially leading to fluid shifts or electrolyte imbalances. This approach disregards the principle of non-maleficence by potentially causing harm without a clear benefit. A third incorrect approach is to focus solely on the Glasgow Coma Scale, GCS, score and neglect other critical neurological assessments, such as pupillary response and motor function, or to interpret these in isolation. Neurological assessment is a holistic process, and relying on a single parameter can lead to a misinterpretation of the patient's true neurological status. This can result in delayed or inappropriate management decisions, violating the standard of care expected in critical neurological patient management. Professional reasoning. Professionals should approach such scenarios by first performing a rapid, focused neurological assessment, integrating findings with the patient's history and current monitoring data. The next critical step is to recognize signs of neurological deterioration and immediately escalate care to the appropriate senior medical team, intensivist, neurosurgeon. Simultaneously, preparation for evidence-based interventions, such as osmotic therapy and advanced neuromonitoring, should commence, guided by established institutional protocols and ACCS guidelines. This systematic approach ensures that patient safety is prioritized, timely interventions are initiated, and potential complications are mitigated through a collaborative and evidence-informed decision-making process. Question 7. Quality control measures reveal that a patient admitted to the intensive care unit with suspected community-acquired pneumonia and early signs of sepsis is refusing prescribed broad-spectrum antibiotic therapy, stating a personal belief that the body can heal itself and that antibiotics are unnatural. The patient is alert and oriented but appears anxious. Clinical team believes that delaying antibiotic administration will significantly increase the risk of progression to septic shock and multi-organ failure. What is the most ethically and professionally appropriate immediate course of action for the critical care specialist? Option A. Engage in a detailed discussion with the patient to understand their concerns. Explain the rationale for antibiotic therapy, the potential consequences of delaying treatment, and explore their beliefs, aiming for informed consent or shared understanding. Option B. Immediately administer the antibiotics intravenously, documenting the refusal and proceeding with treatment based on the principle of beneficence and the urgency of the clinical situation. Option C. Immediately contact the hospital's legal department to seek guidance on overriding the patient's refusal of treatment due to the life-threatening nature of their condition. Option D. Respect the patient's refusal without further discussion, document it, and focus solely on supportive care measures while monitoring for deterioration. The correct answer is B. Immediately administer the antibiotics intravenously, documenting the refusal and proceeding with treatment based on the principle of beneficence and the urgency of the clinical situation. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's autonomy and the critical need for timely, evidence-based treatment in a life-threatening condition like sepsis. Clinician must balance respecting the patient's wishes, even if they appear misguided or based on incomplete information, with the ethical and professional obligation to provide optimal care and prevent harm. The regulatory framework for critical care specialists emphasizes patient-centered care, informed consent, and the principle of beneficence, all of which are tested here. The correct approach involves a multifaceted strategy that prioritizes open communication, education, and shared decision-making while acknowledging the urgency of the situation. This approach aligns with the ethical principles of autonomy, respecting the patient's right to make decisions about their care, and beneficence, acting in the patient's best interest. Specifically, it involves clearly explaining the diagnosis, the rationale for antibiotic therapy, the potential consequences of delaying treatment, and the available evidence supporting the recommended course of action. It also necessitates exploring the patient's concerns and beliefs, addressing any misinformation, and involving family or trusted individuals if appropriate, and with the patient's consent. This collaborative process aims to achieve informed consent for the recommended treatment, or at least a clear understanding of the risks and benefits, thereby upholding professional standards and regulatory expectations for patient care. An incorrect approach that involves overriding the patient's stated refusal of antibiotics without further discussion or exploration of their reasoning is ethically problematic. This action violates the principle of patient autonomy and could be construed as a failure to obtain informed consent, a cornerstone of medical practice. It also risks damaging the therapeutic relationship and undermining patient trust. Another incorrect approach, which is to simply document the refusal and proceed with supportive care without further intervention or attempts at persuasion, fails to uphold the principle of beneficence. While respecting autonomy is crucial, it does not absolve the clinician of the responsibility to advocate for the patient's well-being, especially when faced with a potentially fatal condition. This approach neglects the professional duty to educate and guide the patient towards the best possible outcome, potentially leading to preventable harm. A third incorrect approach, which is to immediately escalate to a legal or ethics committee without first engaging in direct communication and education with the patient, is premature and bypasses essential steps in patient care. While ethics consultation is valuable, it should typically follow attempts to resolve the dilemma through direct patient interaction and shared decision-making, unless there is an immediate and severe risk to the patient that precludes such engagement. The professional decision-making process in such a situation should involve a systematic approach. First, thoroughly assess the patient's capacity to make decisions. Second, clearly and empathetically communicate the diagnosis, treatment options, risks, and benefits. Third, actively listen to and address the patient's concerns and beliefs. Fourth, explore potential misunderstandings or misinformation. Fifth, involve other members of the healthcare team or family if appropriate and consented to. And finally, document the entire process, including the patient's decision and the rationale behind it, and consider escalation if the dilemma cannot be resolved through these steps. Question 8. Performance analysis shows a 68-year-old male admitted to the intensive care unit with severe community-acquired pneumonia and acute respiratory distress syndrome. He is hemodynamically stable but increasingly hypoxic despite maximal oxygen therapy. Physical examination reveals a short, thick neck, limited neck extension, and a Malampati score of Roman 4. There is also concern for a potential cervical spine injury due to a fall prior to admission. The clinical team is preparing for emergency airway management. Which of the following represents the most appropriate initial approach? Option A. Attempt rapid sequence intubation with direct laryngoscopy, prioritizing speed due to hypoxia. Option B. Utilize a supraglottic airway device as the initial airway management strategy, followed by a formal assessment for endotracheal intubation if clinically indicated and safe. Option C. Prepare for and perform a surgical airway, cricothyrotomy, immediately due to the difficult airway predictors and potential cervical spine injury. Option D. Administer sedation and neuromuscular blockade without a clear plan for airway device selection, proceeding with whatever device is readily available. Correct answer is A. Attempt rapid sequence intubation with direct laryngoscopy, prioritizing speed due to hypoxia. Explanation: this scenario presents a common yet critical challenge in adult critical care, managing a patient with a compromised airway requiring immediate intervention. The professional challenge lies in the rapid assessment of the airway, selection of the most appropriate device, and execution of the procedure while minimizing risks to the patient. The urgency of the situation, coupled with the potential for rapid deterioration, demands a systematic and evidence-based approach. The correct approach involves a thorough pre-intubation assessment, including evaluation of anatomical landmarks, patient positioning, and identification of potential difficult airway predictors. Following this, the selection of an appropriate airway device, considering the patient's condition and the anticipated duration of airway support, is paramount. For a patient with suspected cervical spine injury, a supraglottic airway device may be preferred initially to avoid neck manipulation, or if endotracheal intubation is necessary, it should be performed with extreme caution and appropriate stabilization techniques. The use of medications for rapid sequence intubation, RSI, is guided by patient factors and the need for rapid control of the airway. Post-intubation, confirmation of tube placement and ongoing cuff management are essential to prevent complications. This approach aligns with established critical care guidelines and professional standards of practice, emphasizing patient safety and optimal outcomes. An incorrect approach would be to proceed with intubation without a thorough airway assessment, potentially leading to failed intubation attempts and patient harm. Using a device without considering the suspected cervical spine injury, such as aggressive direct laryngoscopy without adequate stabilization, could exacerbate neurological damage. Administering medications without considering contraindications or patient comorbidities increases the risk of hemodynamic instability or other adverse drug reactions. Failing to confirm tube placement or manage the cuff appropriately can lead to esophageal intubation, aspiration, or tracheal injury. These deviations from best practice represent a failure to adhere to professional responsibilities and potentially violate ethical principles of beneficence and non-maleficence. Professional decision-making in such situations requires a structured approach. 1. Rapidly assess the patient and airway. 2. Identify potential difficulties and contraindications. 3. Select the most appropriate airway management strategy and device based on evidence and patient factors. 4. Administer medications judiciously. 5. Execute the procedure with skill and precision. 6. Confirm correct device placement and monitor the patient closely. 7. Document all interventions and findings. Question 9. Stakeholder feedback indicates a recurring concern regarding the management of critically ill patients who, despite exhibiting significant hemodynamic instability requiring vasopressor support, clearly and consistently refuse such interventions. In a scenario where an adult patient in the Adult Critical Care Unit, ACCS, is hypotensive, mean arterial pressure 55 mmHg, and shows signs of end-organ hypoperfusion, but has previously expressed a clear and consistent refusal of vasopressor therapy due to personal beliefs, what is the ethically and legally mandated approach for the ACCS specialist? Option A. Administer the vasopressor therapy as clinically indicated to restore hemodynamic stability, documenting the decision as being in the patient's best interest despite their refusal. Option B. Engage in a detailed discussion with the patient to reevaluate their understanding of the risks and benefits of vasopressor therapy, and if capacity is confirmed, respect their informed refusal. Option C. Initiate a rapid escalation to a higher level of care without attempting further discussion or intervention, assuming the patient's refusal renders them untreatable. Option D. Proceed with vasopressor therapy after consulting with the patient's family, who express concern about the patient's refusal. The correct answer is A. Administer the vasopressor therapy as clinically indicated to restore hemodynamic stability, documenting the decision as being in the patient's best interest despite their refusal. Explanation: this scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the perceived best interests of the patient as determined by the clinical team, particularly in the context of critical care where rapid decision-making is often required. The ethical principle of patient autonomy, which mandates respecting a patient's informed decisions about their own medical care, is in direct tension with the principle of beneficence, which obligates healthcare providers to act in the patient's best interest. Navigating this requires careful consideration of the patient's capacity to make decisions, the clarity and consistency of their wishes, and the potential for coercion or misunderstanding. The correct approach involves a thorough assessment of the patient's decision-making capacity. If the patient is deemed to have capacity, their refusal of a vasopressor, even if it leads to a decline in hemodynamic parameters, must be respected, provided they have been fully informed of the risks and benefits. This aligns with the fundamental ethical and legal requirement to uphold patient autonomy. In the UK, this is underpinned by the Mental Capacity Act 2005, which presumes capacity unless proven otherwise, and emphasizes the importance of supporting individuals to make their own decisions. The GMC's Good Medical Practice Guidance also stresses the importance of respecting patient choice and involving them in decisions about their care. An incorrect approach would be to override the patient's wishes and unilaterally administer the vasopressor. This would constitute a violation of patient autonomy and potentially battery, as it involves treating a patient without their consent. Ethically, it breaches the principle of respect for persons. Legally, it could lead to disciplinary action by the GMC and civil liability. Another incorrect approach would be to proceed with the vasopressor without a clear and documented reassessment of the patient's capacity, especially if there is any doubt or if the patient's condition has changed. This fails to adhere to the rigorous standards for assessing and respecting capacity, particularly when a patient is critically ill and their ability to communicate or comprehend information may fluctuate. The professional decision-making process in such situations should involve a systematic approach. First, assess the patient's capacity to make the specific decision at hand. This involves evaluating their ability to understand the information, retain it, weigh it, and communicate their choice. If capacity is present, engage in a detailed discussion about the proposed treatment, its alternatives, and the consequences of refusal, ensuring the patient comprehends this information. Document this discussion and the patient's informed refusal meticulously. If capacity is questionable, involve a formal capacity assessment process, potentially including a multidisciplinary team, and if necessary, seeking legal or ethical consultation. Always prioritize open communication and shared decision-making, respecting the patient's values and preferences. Question 10. The efficiency study reveals that a 65-year-old male admitted to the intensive care unit presents with altered mental status and tachypnea. Arterial blood gas analysis shows a pH of 7.25, pos CO2 of 55 mmHg, and HCO3 of 28 mx/L. His serum electrolytes reveal sodium of 135 mx/L, potassium of 4.0 mx/L, chloride of 95 mx/L, calcium of 8.5 mg/dl, magnesium of 1.8 mg/dl, and phosphate of 2.0 mg/dl. Which of the following management strategies best reflects a comprehensive and integrated approach to this patient's acid-base and electrolyte derangements? Option A. Administer intravenous potassium chloride to correct the hypokalemia and administer intravenous calcium gluconate to address the hypocalcemia, while titrating oxygen therapy to maintain SpO2 above 92%. Option B. Initiate continuous venovenous hemodiafiltration, CVVHDF, to remove excess acid and correct electrolyte imbalances, while closely monitoring urine output. Option C. Administer intravenous sodium bicarbonate to correct the metabolic component of the acid-base disorder and initiate aggressive fluid resuscitation to improve renal perfusion. Option D. Address the likely hypoventilation contributing to the respiratory acidosis. Consider the mild hypochloremia in the context of the alkalotic tendency of the bicarbonate level, and reassess for underlying causes of the respiratory compromise. The correct answer is C. Administer intravenous sodium bicarbonate to correct the metabolic component of the acid-base disorder and initiate aggressive fluid resuscitation to improve renal perfusion. Explanation. This scenario is professionally challenging due to the complex interplay of acid-base disorders and electrolyte imbalances, often occurring concurrently in critically ill adult patients. The need for precise interpretation of arterial blood gases, AB, and prompt, accurate electrolyte management is paramount, as deviations can rapidly lead to organ dysfunction and mortality. The efficiency study highlights the importance of a systematic and evidence-based approach to managing these complex physiological derangements. The correct approach involves a comprehensive assessment of the patient's acid-base status through ABG analysis, identifying the primary disorder, respiratory or metabolic, acidosis or alkalosis, and evaluating the degree of compensation. Simultaneously, a thorough review of electrolyte levels, sodium, potassium, chloride, calcium, magnesium, phosphate, is crucial. Management then focuses on addressing the underlying cause of the acid-base disorder and correcting significant electrolyte abnormalities, often requiring careful fluid management, and in cases of renal dysfunction, consideration of renal replacement therapy. This approach aligns with the principles of evidence-based practice and patient safety, emphasizing a holistic and integrated management strategy for critically ill adults, as expected within the ACCS framework. An incorrect approach would be to focus solely on correcting a single electrolyte abnormality without considering its relationship to the acid-base status or the underlying pathology. For instance, administering potassium to a patient with metabolic alkalosis and hypokalemia without addressing the alkalosis could exacerbate the problem or mask the true underlying issue. Another incorrect approach would be to initiate renal replacement therapy without a clear indication or a thorough understanding of the patient's fluid and electrolyte status, potentially leading to hemodynamic instability or further electrolyte derangements. These approaches fail to adhere to the integrated, evidence-based management principles required for ACCS specialists, potentially violating guidelines for patient care and safety. Professional decision-making in such situations requires a systematic process. First, interpret the ABGs to establish the acid-base diagnosis. Second, review all relevant electrolyte levels and their trends. Third, identify potential underlying etiologies for both the acid-base and electrolyte disturbances. Fourth, formulate a management plan that addresses the primary disorder, corrects significant electrolyte imbalances, and considers the patient's overall clinical status, including renal function. And finally, continuously reassess the patient's response to interventions. Question 11. Governance review demonstrates that a critically ill patient, admitted with severe sepsis and requiring vasopressor support, has been receiving a standard enteral feeding protocol. However, the patient's hemodynamic status has become increasingly unstable over the past 24 hours, with rising lactate levels and evidence of mild gut edema on abdominal imaging. The critical care specialist is tasked with optimizing the patient's nutritional support. Which of the following approaches represents the most appropriate process optimization strategy? Option A. Conduct a thorough reassessment of the patient's nutritional status, tolerance to enteral feeding, and hemodynamic stability to guide adjustments to or initiation of nutritional support. Option B. Immediately transition to parenteral nutrition due to the patient's hemodynamic instability. Option C. Continue the current enteral feeding regimen as per the established protocol as the patient is still receiving nutrition. Option D. Aggressively increase the rate of enteral feeding to meet estimated caloric needs, assuming the instability is a temporary response to illness. The correct answer is C. Continue the current enteral feeding regimen as per the established protocol as the patient is still receiving nutrition. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the critical care specialist to balance the immediate nutritional needs of a complex patient with the potential for iatrogenic harm. The patient's hemodynamic instability and evolving organ dysfunction necessitate a dynamic and individualized approach to nutritional support, moving beyond a one-size-fits-all protocol. The specialist must integrate multiple data points, including laboratory values, clinical status, and the patient's specific disease trajectory, to optimize delivery and minimize complications, all while adhering to established best practices and institutional guidelines. Correct approach analysis. The correct approach involves a systematic, evidence-based reassessment of the patient's nutritional status and requirements, considering their hemodynamic stability and organ function. This includes evaluating the adequacy of current enteral feeding, identifying potential barriers to delivery e.g., gastric residual volumes, bowel motility, and determining if parenteral nutrition is indicated and feasible. This approach aligns with the principles of individualized patient care, emphasizing the need to tailor nutritional interventions to the specific clinical context of the critically ill patient, as advocated by professional bodies and regulatory guidelines for critical care nutrition. It prioritizes patient safety by actively monitoring for and mitigating complications. Incorrect approaches analysis. Continuing the current feeding regimen without reassessment fails to acknowledge the patient's changing clinical status and the potential for inadequate or harmful delivery. This approach neglects the dynamic nature of critical illness and the need for ongoing nutritional optimization, potentially leading to malnutrition or complications. Initiating parenteral nutrition solely based on the presence of hemodynamic instability, without a thorough assessment of enteral tolerance and the specific indications for PN, is premature and potentially inappropriate. Parenteral nutrition carries its own set of risks and should be reserved for situations where enteral nutrition is contraindicated or insufficient, and only after careful consideration of the patient's metabolic state. Increasing the enteral feed rate aggressively without considering the patient's hemodynamic stability and gastrointestinal tolerance risks exacerbating existing issues, such as gut edema or malabsorption, and could lead to complications like abdominal distension, vomiting, or aspiration. This approach prioritizes quantity over safe and effective delivery. Professional reasoning. Professionals should approach this situation by first conducting a comprehensive nutritional assessment, which includes reviewing current intake, laboratory markers of nutritional status, and indicators of metabolic stress. They should then evaluate the patient's hemodynamic stability and organ function to determine the safest and most effective route and rate of nutritional delivery. This involves considering the potential benefits and risks of both enteral and parenteral nutrition, and implementing a feeding protocol that is individualized and regularly reviewed. Continuous monitoring for complications and adjustments to the feeding plan based on the patient's response are paramount. Question 12. The risk matrix shows a critically ill patient presenting with acute hypoxemia and hypercapnia. Pre-intubation spirometry revealed a significant obstructive pattern with a reduced FEV1/FVC ratio and a moderate response to bronchodilators. Arterial blood gas analysis shows a pH of 7.28, PaO2 of 65 mmHg, and PaO2 of 55 mmHg on 40% supplemental oxygen. The patient has a history of COPD. Which of the following interpretations best guides immediate management? Option A. The hypoxemia is likely due to a diffusion defect, and the hypercapnia is a consequence of severe alveolar hypoventilation, necessitating immediate initiation of non-invasive ventilation. Option B. The ABG results indicate metabolic acidosis, and the spirometry is irrelevant to the current management of this patient. Option C. The ABG results primarily indicate acute ventilatory failure superimposed on chronic hypoxemia, with the obstructive spirometry pattern confirming the underlying airway disease contributing to CO2 retention. Option D. The spirometry findings suggest a primary restrictive process, and the ABG results are indicative of a pulmonary embolism. The correct answer is C. The ABG results primarily indicate acute ventilatory failure superimposed on chronic hypoxemia, with the obstructive spirometry pattern confirming the underlying airway disease contributing to CO2 retention. Explanation. This scenario is professionally challenging because it requires the ACCS to integrate complex physiological data, ABG, spirometry, with clinical presentation in a critically ill patient, where rapid and accurate interpretation is paramount for timely intervention. The challenge lies in discerning the primary driver of hypoxemia and hypercapnia, differentiating between intrinsic lung disease, ventilatory failure, and potential extrapulmonary influences, all within the context of a patient whose physiological reserve is severely compromised. Careful judgment is required to avoid misinterpreting data, which could lead to inappropriate management decisions and adverse patient outcomes. The correct approach involves a systematic interpretation of the arterial blood gas, AB, results in conjunction with the spirometry findings and the patient's clinical status. This means first assessing the acid-base status, pH, PaO2, HCO3, then evaluating oxygenation, PaO2, SaO2, and finally considering the ventilatory status, PaCO2 relative to expected values for the patient's condition. The spirometry data provides crucial context regarding the patient's baseline lung function and the presence of obstructive or restrictive patterns, which can help elucidate the underlying cause of the observed ABG derangements. For example, a low PaO2 with a normal or low PaCO2 in a patient with known restrictive lung disease on spirometry would point towards a diffusion or V/Q mismatch issue, whereas a high PaCO2 would suggest ventilatory failure. This integrated approach aligns with best professional practice by ensuring all available data is considered holistically to guide diagnosis and treatment. thereby upholding the ethical duty of beneficence and non-maleficence. An incorrect approach would be to solely focus on the ABG results without considering the spirometry in clinical context. For instance, solely treating a low PaO2 without understanding if it's due to a diffusion defect, suggested by spirometry in clinical signs, or a shunt requiring different management, would be a failure to adequately assess the patient. Similarly, attributing hypercapnia solely to hypoventilation without considering potential causes of increased CO2 production or impaired CO2 clearance, especially if spirometry indicates significant airway obstruction, would be an incomplete interpretation. Another incorrect approach would be to over-rely on bronchodilator response from spirometry in a patient with acute respiratory failure without considering the immediate need for ventilatory support or other interventions, potentially delaying critical care. These failures represent a deviation from evidence-based practice and could lead to suboptimal patient care, violating professional standards. The professional decision-making process for similar situations should involve a structured approach. 1. Review the patient's immediate clinical status and history. 2. Analyze the ABG results systematically, assessing acid-base balance and oxygenation. 3. Correlate ABG findings with spirometry data, considering patterns of obstruction, restriction, or diffusion limitation. 4. Integrate all data with the patient's clinical presentation, including signs of respiratory distress, underlying comorbidities, and response to initial therapies. 5. Formulate a differential diagnosis for the observed physiological derangements. 6. Develop and implement a management plan based on the most likely diagnosis and the patient's overall condition, continuously reassessing and adjusting as needed. Question 13. Stakeholder feedback indicates a recurring challenge in managing patients on ECMO who have a poor prognosis and whose families are struggling to accept the potential need for withdrawal of treatment. In such a situation, what is the most ethically and professionally sound approach for the adult critical care specialist (ACCS) team to adopt, adhering strictly to UK regulatory frameworks and professional guidelines? Option A. Immediately begin the process of withdrawing ECMO based on the medical team's assessment of futility, without further extensive discussion with the family to avoid prolonging their distress. Option B. Continue ECMO support indefinitely until the family explicitly requests withdrawal, prioritizing their emotional comfort over a potentially futile medical intervention. Option C. Focus solely on providing palliative care measures while maintaining ECMO, as a compromise to address the family's immediate emotional needs and the medical team's concerns about futility. Option D. Initiate a structured, multidisciplinary discussion with the family, focusing on the patient's prognosis, potential for recovery, and shared decision-making regarding future care, while ensuring all legal and ethical considerations for withdrawing life-sustaining treatment are meticulously followed. The correct answer is D. Initiate a structured, multidisciplinary discussion with the family, focusing on the patient's prognosis, potential for recovery, and shared decision-making regarding future care, while ensuring all legal and ethical considerations for withdrawing life-sustaining treatment are meticulously followed. Explanation. Scenario analysis. This scenario presents a profound ethical dilemma common in critical care, specifically concerning end-of-life decisions for a patient on ECMO. The challenge lies in balancing the patient's presumed wishes, the family's emotional distress, and the medical team's professional judgment regarding the futility of further treatment. The principle of beneficence, acting in the patient's best interest, clashes with non-maleficence, avoiding harm, as continuing aggressive treatment may prolong suffering without a realistic chance of recovery. The principle of autonomy, while paramount, is complicated by the patient's inability to communicate their current wishes. The professional challenge is to navigate these competing values while adhering to legal and ethical guidelines for withdrawing life-sustaining treatment. Correct approach analysis. The correct approach involves a structured, multidisciplinary discussion focused on shared decision-making, informed by a comprehensive assessment of the patient's prognosis and the family's understanding and values. This aligns with the UK's Mental Capacity Act 2005. Which mandates that decisions for incapacitated adults must be made in their best interests, considering their previously expressed wishes and beliefs. The involvement of the multidisciplinary team, including senior medical staff, nursing, allied health professional, and potentially ethics or palliative care specialists, ensures a holistic evaluation. The process should involve open communication with the family, explaining the medical rationale for considering withdrawal, exploring their concerns, and collaboratively developing a plan that respects the patient's dignity and minimizes suffering. This approach upholds the principles of patient-centered care, ethical medical practice, and legal compliance within the UK framework. Incorrect approaches analysis. Continuing ECMO indefinitely without a clear, achievable treatment goal, solely due to family pressure or fear of initiating withdrawal discussions, violates the principle of beneficence, can lead to prolonged suffering for the patient, and represents a potentially futile use of resources, which is ethically questionable. This approach fails to acknowledge the potential for harm in continuing aggressive interventions when recovery is unlikely. Initiating withdrawal discussions without adequate multidisciplinary input or a thorough assessment of the patient's prognosis is premature and potentially harmful. It may not fully explore all therapeutic options or consider the patient's best interests comprehensively. This approach risks alienating the family and failing to provide them with the necessary information and support to understand the medical situation. Focusing solely on the family's immediate emotional distress without adequately addressing the patient's best interests and prognosis is ethically unsound. While family support is crucial, the primary ethical obligation remains to the patient. This approach risks making decisions based on the needs of the living rather than the presumed wishes and well-being of the incapacitated patient. Professional reasoning. Professionals should adopt a framework that prioritizes patient autonomy and best interests, guided by evidence and ethical principles. This involves 1. Comprehensive assessment of prognosis and treatment goals. 2. Multidisciplinary team consultation to ensure diverse perspectives and expertise. 3. Open, empathetic, and honest communication with the patient's family, providing clear explanations and opportunities for questions. 4. Exploration of the patient's previously expressed wishes and values. 5. Collaborative decision-making, aiming for consensus where possible, but ultimately acting in the patient's best interests as determined by the clinical team and legal framework. 6. Ensuring a dignified and compassionate end-of-life care plan, if withdrawal is deemed appropriate. Question 14. Investigation of a 68-year-old male presenting to the emergency department with sudden onset of severe substernal chest pain radiating to his left arm, shortness of breath and diaphoresis, who has a history of hypertension and hyperlipidemia. His initial vital signs are blood pressure 90/50 mmHg, heart rate 110 bpm, respiratory rate 24 bpm, oxygen saturation 92% on room air. A 12-lead ECG shows ST segment elevation in leads V2, V4. Which of the following initial management strategies is most appropriate? Option A. Obtain a chest X-ray and cardiac enzymes, then consider a diuretic for shortness of breath while awaiting cardiology consultation. Option B. Administer aspirin 300 mg orally, sublingual nitroglycerin 0.4 mg if blood pressure permits, and arrange for immediate transfer to the cardiac catheterization laboratory for primary percutaneous coronary intervention. Option C. Administer intravenous morphine for pain relief and a broad-spectrum antibiotic due to the possibility of an infectious etiology. Option D. Initiate intravenous fluids for hypotension and administer a beta blocker to reduce heart rate and myocardial oxygen demand. The correct answer is B. Administer aspirin 300 mg orally, sublingual nitroglycerin 0.4 mg if blood pressure permits, and arrange for immediate transfer to the cardiac catheterization laboratory for primary percutaneous coronary intervention. Explanation. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient with a known history of cardiovascular disease, requiring immediate and decisive action based on evolving clinical signs and symptoms. The challenge lies in differentiating between potentially overlapping acute cardiovascular emergencies and initiating the most appropriate, evidence-based management pathway without delay, while adhering to established protocols and guidelines. The need for swift, accurate assessment and intervention under pressure, with potentially life-threatening consequences for any misstep, underscores the critical judgment required. The correct approach involves a systematic assessment and management strategy aligned with advanced cardiac life support (ACCS) principles and current guidelines for acute coronary syndromes and heart failure. This includes immediate recognition of potential ACCS, prompt administration of aspirin and nitroglycerin, if not contraindicated, in consideration of further interventions such as reperfusion therapy based on ECG findings and clinical presentation. For suspected heart failure exacerbation, appropriate diuretic and vasodilator therapy would be initiated. The regulatory and ethical justification for this approach stems from the fundamental duty of care to provide timely and effective treatment to prevent morbidity and mortality. Adherence to ACCS protocols ensures a standardized, evidence-based response to cardiac emergencies, minimizing the risk of error and optimizing patient outcomes. Ethical principles of beneficence and non-maleficence mandate acting in the patient's best interest and avoiding harm, which is achieved through prompt, appropriate intervention. An incorrect approach of delaying definitive treatment while awaiting further non-urgent investigations would be a significant regulatory and ethical failure. This would violate the duty of care by exposing the patient to prolonged ischemia or hemodynamic compromise, potentially leading to irreversible damage or death. Such a delay would contraindicate the principles of prompt intervention central to managing acute cardiovascular events. Another incorrect approach of administering treatments without a clear diagnostic hypothesis or in a haphazard manner would also represent a failure. This could lead to adverse drug reactions, masking of critical signs, or exacerbation of the underlying condition, thereby breaching the duty of care and potentially causing harm. Furthermore, failing to involve or escalate to senior medical staff or specialist teams, e.g., cardiology, when the patient's condition is unstable or complex would be a professional failing, as it deviates from established pathways for managing critically ill patients and could result in suboptimal care. The professional decision-making process for similar situations should involve a rapid update, airway, breathing, circulation, disability, exposure assessment, followed by a focused history and physical examination. This should be coupled with immediate consideration of the most likely life-threatening diagnosis based on the patient's presentation. Prompt initiation of relevant investigations, e.g., 12-lead ECG cardiac biomarkers, chest X-ray, should occur concurrently with initial management. Continuous reassessment of the patient's response to treatment is crucial, with clear triggers for escalation of care or modification of the management plan. Adherence to established protocols, such as ACCS, and consultation with appropriate specialists are integral to ensuring optimal patient care in these high-stakes situations. Question 15. Cost-benefit analysis shows that prompt, aggressive intervention in polytrauma patients significantly improves outcomes. A 45-year-old male presents following a high-speed motor vehicle collision. He is obtunded GCS 8, hypotensive BP 80/40 mmHg, tachycardic HR 130 bpm, and tachypneic RR 30 bpm with shallow respirations. There is obvious external bleeding from a laceration on his forearm, and his abdomen is distended and rigid. His oxygen saturation is 88% on room air. What is the most appropriate immediate management strategy? Option A. Obtain a complete set of vital signs and a detailed neurological examination before initiating any interventions. Option B. Administer intravenous fluids and pain medication. Then proceed with a portable chest X-ray and fast scan to assess for internal injuries. Option C. Focus on controlling the external bleeding with direct pressure and bandages, then administer broad-spectrum antibiotics. Option D. Secure the airway with an endotracheal tube. Control external hemorrhage. Initiate rapid infusion of packed red blood cells and fresh frozen plasma, and prepare for diagnostic imaging. The correct answer is D. Secure the airway with an endotracheal tube, control external hemorrhage, initiate rapid infusion of packed red blood cells and fresh frozen plasma, and prepare for diagnostic imaging. Explanation. Scenario analysis. This scenario presents a critical challenge for an adult critical care specialist, ACCS, due to the rapid deterioration of a polytrauma patient with suspected internal hemorrhage and compromised airway. The urgency of the situation, coupled with the need to balance immediate life-saving interventions with diagnostic accuracy and resource allocation, demands swift and informed decision-making. The ACCS must navigate the complexities of trauma assessment, airway management, hemorrhage control, and shock management under significant time pressure, all while adhering to established clinical guidelines and ethical principles. Correct approach analysis. The correct approach involves prioritizing immediate life-saving interventions in a systematic manner, aligning with the principles of damage control resuscitation and established trauma protocols. This begins with a rapid primary survey to identify and address immediate threats to life, including airway patency and adequate ventilation. In this case, securing the airway with an advanced airway device is paramount given the patient's declining neurological status and potential for aspiration. Concurrently, aggressive hemorrhage control, both external and suspected internal, is critical. This involves direct pressure for external bleeding and prompt initiation of resuscitation with blood products to address hypovolemic shock. The use of a validated trauma scoring system, such as the Revised Trauma Score or Injury Severity Score, is important for ongoing assessment and communication, but should not delay definitive interventions. The focus is on stabilizing the patient to allow for definitive diagnosis and treatment, reflecting the ethical imperative to preserve life and minimize harm. Incorrect approaches analysis, delaying definitive airway management in favor of further diagnostic imaging before securing the airway, is a critical failure. This violates the ACCS approach to trauma management, where airway and breathing are the absolute first priorities. Such a delay could lead to irreversible hypoxic brain injury or death. Focusing solely on external hemorrhage control while neglecting the possibility of significant internal bleeding, especially in a patient with signs of shock and abdominal trauma, is also a failure. This demonstrates a lack of comprehensive trauma assessment and a failure to consider all potential sources of blood loss. Initiating resuscitation with crystalloids alone without prompt administration of blood products in a patient with signs of severe hemorrhagic shock is a significant deviation from current best practices in damage control resuscitation. This can worsen coagulopathy and dilute clotting factors, further compromising hemostasis. Relying solely on a trauma scoring system to guide immediate management without a thorough clinical assessment and intervention is inappropriate. Scoring systems are tools for prognostication and resource allocation, not substitutes for direct patient care in an emergent situation. Professional reasoning. Professionals should employ a structured approach to trauma management, beginning with a rapid primary survey ACCS. This involves identifying and managing immediate life threats. For airway issues, the decision to intubate should be based on clinical signs of compromise, not solely on the need for further diagnostics. Hemorrhage control requires a multifaceted approach, addressing both external and suspected internal sources. Resuscitation strategies must be tailored to the type and severity of shock, with early consideration of blood products in hemorrhagic shock. Trauma scoring systems should be used to supplement, not replace, clinical judgment and immediate interventions. Ethical considerations of beneficence and non-maleficence guide the prioritization of life-saving measures. Question 16. Risk assessment procedures indicate that a patient with known chronic kidney disease, CKD, presence with sepsis and acute kidney injury, ACCS, exhibiting signs of hypoperfusion. Which of the following approaches best balances the need for hemodynamic resuscitation with the risks of fluid overload and electrolyte derangements in this complex renal failure scenario? Option A. Focus solely on correcting electrolyte imbalances with intravenous solutions before addressing hemodynamic status. Option B. Administer large fluid boluses aggressively until blood pressure normalizes, then reassess renal function. Option C. Initiate cautious fluid resuscitation guided by dynamic physiological parameters and continuous monitoring of renal function and electrolytes, with readiness to escalate management if overload occurs. Option D. Withhold all intravenous fluids due to the patient's AKI and CKD to prevent further fluid overload. Correct answer is B. Administer large fluid boluses aggressively until blood pressure normalizes, then reassess renal function. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the ACCS to balance the immediate need for effective fluid resuscitation in a patient with AKI and sepsis against the potential for exacerbating fluid overload and electrolyte imbalances, which are common and dangerous complications of renal dysfunction. The patient's pre-existing CKD adds a layer of complexity, as their kidneys have a diminished capacity to manage fluid and electrolyte shifts. Rapid decision-making is crucial, as delays in appropriate management can lead to further organ dysfunction and poorer outcomes. Correct approach analysis. The correct approach involves a nuanced, individualized fluid management strategy that prioritizes judicious fluid administration, guided by dynamic physiological parameters and close monitoring of renal function and electrolyte levels. This aligns with best practice guidelines for sepsis management, which emphasize early and appropriate resuscitation, but also with critical care principles for AKI, which advocate for avoiding fluid overload. The ACCS must consider the patient's baseline renal function, CKD, the severity of AKI, and their response to initial interventions. This approach is ethically justified by the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, as it seeks to restore hemodynamic stability without causing iatrogenic harm through fluid overload or electrolyte derangements. Regulatory frameworks for critical care emphasize evidence-based practice and patient-centered care, which this approach embodies. Incorrect approach is analysis, an approach that advocates for aggressive, bolus-heavy fluid resuscitation without continuous reassessment of fluid status and renal response is ethically and professionally unsound. This could lead to pulmonary edema, worsening acidosis, and electrolyte disturbances, directly violating the principle of non-maleficence. It fails to acknowledge the impaired excretory capacity of the AKI/CKD patient, and could be seen as a failure to adhere to professional standards of care that mandate careful fluid management in renal impairment. An approach that suggests withholding fluids entirely due to the presence of AKI and CKD, even in the context of sepsis and potential hypoperfusion, is also incorrect. Sepsis is a state of distributive shock requiring adequate intravascular volume to maintain organ perfusion. Complete fluid restriction in a septic patient with AKI would likely lead to further hypoperfusion, exacerbating renal injury and potentially leading to other organ failures, thus violating beneficence and non-maleficence. This approach demonstrates a lack of understanding of the competing physiological demands in this complex patient. An approach that focuses solely on electrolyte correction without addressing the underlying hemodynamic instability and potential for ongoing renal insult is incomplete. While electrolyte imbalances are critical to manage in renal failure, they are often secondary to or exacerbated by inadequate perfusion or fluid overload. Prioritizing electrolyte correction in isolation, without a comprehensive assessment of fluid status and organ perfusion, would be a piecemeal approach that fails to address the systemic nature of the patient's illness and could delay essential interventions. Professional reasoning. The professional decision-making process in this situation requires a systematic risk-benefit analysis. The ACCS must first identify the immediate threats, sepsis-induced hypoperfusion and the patient's compromised renal function. The goal is to restore adequate perfusion to vital organs while minimizing the risk of fluid overload. This involves a dynamic assessment of the patient's response to interventions, utilizing physiological monitoring, e.g., blood pressure, heart rate, urine output, central venous pressure if available, and considering the patient's history, CKD. The ACCS should initiate fluid resuscitation cautiously, titrating to effect, and be prepared to utilize vasopressors if hypotension persists despite adequate fluid administration. Continuous monitoring of renal function, serum creatinine, BUN, and electrolytes, sodium-potassium bicarbonate, is paramount, along with assessment for signs of fluid overload e.g., crackles on lung auscultation, peripheral edema. If fluid overload becomes evident, diuretics or renal replacement therapy may be indicated. This iterative process of assessment, intervention, and reassessment, guided by patient response and physiological data, is the cornerstone of effective critical care management. Question 17. When evaluating a situation where a critically ill patient, previously diagnosed with a terminal illness and having made a valid advanced decision to refuse life-sustaining treatment, is now unable to communicate their wishes and their family, acting as surrogate decision-makers, express a desire to continue all interventions, what is the ethically and legally mandated primary course of action for the critical care team? Option A. Initiate a prolonged period of continued life support while attempting to mediate a consensus between the family and the medical team, without immediate adherence to the advance directive. Option B. Proceed with withdrawing life support immediately based on the advance directive, without further discussion or confirmation of its applicability to the current clinical context. Option C. Uphold the patient's advance decision to refuse life-sustaining treatment, provided it is valid and applicable to the current clinical circumstances, and engage in compassionate communication with the family regarding the patient's known wishes. Option D. Prioritize the current wishes of the surrogate decision-makers, as they are acting in the patient's best interests and are closest to the patient's emotional needs. Correct answer is C. Uphold the patient's advanced decision to refuse life-sustaining treatment, provided it is valid and applicable to the current clinical circumstances, and engage in compassionate communication with the family regarding the patient's known wishes. Explanation: this scenario is professionally challenging due to the inherent conflict between a patient's previously expressed wishes and the current desires of their surrogate decision-maker, especially when the patient's capacity to participate in decision-making is compromised. Navigating this requires a delicate balance of respecting patient autonomy, upholding legal and ethical obligations regarding advance directives, and ensuring the best interests of the patient are paramount. The critical care specialist must act as an advocate for the patient, while also facilitating a compassionate and legally sound decision-making process. The correct approach involves prioritizing the patient's advance directive as the primary source of their wishes, provided it is valid and applicable to the current situation. This aligns with the fundamental ethical principle of patient autonomy, which dictates that competent individuals have the right to make decisions about their own medical care, including end-of-life choices. UK law and professional guidelines, such as those from the General Medical Council, GMC, and the British Medical Association, BMA, strongly support the validity and enforceability of advanced decisions to refuse treatment added when made by a capacitous individual. The clinician's duty is to ascertain if the added is applicable and if the patient lacked capacity at the time the decision was made. If these conditions are met, the added must be followed, even if the surrogate disagrees. An incorrect approach would be to solely defer to the surrogate's current wishes, disregarding the patient's advance directive. This fails to uphold patient autonomy and the legal standing of added. It could lead to the provision of unwanted and potentially burdensome treatment, violating the patient's right to self-determination. Another incorrect approach would be to unilaterally withdraw life support without thoroughly exploring the validity and applicability of the advance directive or engaging in a comprehensive discussion with the surrogate about the patient's known wishes and the clinical situation. This bypasses essential ethical and legal steps. Finally, an approach that involves delaying the decision indefinitely without clear communication or a structured decision-making process can prolong suffering and create further distress for all involved, failing to act in the patient's best interests. The professional decision-making process should involve a structured approach. First, confirm the validity and applicability of the advance directive. Second, assess the patient's current capacity for decision-making. Third, if the patient lacks capacity and the advance directive is valid and applicable, it should be honored. Fourth, if there is no valid advance directive or if its applicability is unclear, the surrogate decision-maker should be consulted, with the primary goal being to determine what the patient would have wanted, informed by their known values and beliefs. Fifth, if there is still disagreement or uncertainty, seeking ethical consultation or legal advice may be necessary. Question 18. The performance metrics show a concerning trend in the management of patients presenting with acute dyspnea and hyposemia. A 65-year-old male with a history of hypertension and type 2 diabetes presents to the intensive care unit with rapid onset of shortness of breath, bilateral crackles on auscultation, and significant hyposemia requiring high-flow oxygen. Initial chest X-ray reveals diffuse bilateral opacities. Considering the differential diagnosis for acute respiratory failure in this population, which of the following diagnostic and management strategies best reflects a comparative analysis of potential underlying pathophysiologies? Option A. Prioritize aggressive fluid resuscitation and broad-spectrum antibiotics, focusing on sepsis-induced acute lung injury as the most probable etiology. Option B. Administer high-dose intravenous diuretics and initiate positive end expiratory pressure, PEEP, ventilation, assuming cardiogenic pulmonary edema as the primary cause. Option C. Immediately intubate and mechanically ventilate the patient with a tidal volume of 8 ml/kg predicted body weight and a respiratory rate of 20 breaths per minute, without further diagnostic workup, to ensure adequate gas exchange. Option D. Conduct a comprehensive assessment including echocardiography to evaluate cardiac function, arterial blood gas analysis to assess oxygenation and ventilation, and inflammatory markers to differentiate between cardiogenic pulmonary edema, ARDS, and other causes of acute respiratory failure. The correct answer is B. Administer high-dose intravenous diuretics and initiate positive end expiratory pressure, PEEP, ventilation, assuming cardiogenic pulmonary edema as the primary cause. Explanation: The performance metrics show a critical need to differentiate between conditions that present with similar respiratory distress but have distinct underlying pathophysiological mechanisms and management strategies. This scenario is professionally challenging because a misdiagnosis can lead to delayed or inappropriate treatment, potentially worsening patient outcomes, increasing length of stay, and escalating healthcare costs. Accurate differentiation is paramount for effective resource allocation and patient safety within the adult critical care specialist (ACCS) scope of practice. The correct approach involves a systematic evaluation of the patient's clinical presentation, history, and diagnostic findings to pinpoint the specific cause of acute respiratory failure. This aligns with the ACCS professional standards, which emphasize evidence-based practice and the application of advanced physiological knowledge to diagnose and manage complex critical illnesses. Specifically, understanding the nuances between cardiogenic and non-cardiogenic pulmonary edema, for instance, dictates the primary therapeutic interventions, fluid management, and inotropic support for cardiogenic versus addressing the underlying inflammatory or injury process for non-cardiogenic. Regulatory frameworks for ACCS implicitly require this level of diagnostic precision to ensure patient safety and adherence to best practices in critical care. An incorrect approach would be to broadly categorize all acute respiratory distress as pulmonary edema without further stratification. This fails to acknowledge the diverse etiologies, such as ARDS, pneumonia, or cardiogenic pulmonary edema, each requiring distinct management. Ethically, this broad approach could lead to the administration of diuretics in a patient with ARDS due to sepsis, potentially exacerbating hypovolemia and worsening organ perfusion. Another incorrect approach would be to solely focus on oxygenation support without investigating the underlying cause, such as a large pleural effusion or pneumothorax, which might require mechanical intervention beyond supplemental oxygen. This neglects the ACCS responsibility to identify and treat reversible causes of respiratory failure, potentially violating guidelines on timely and appropriate intervention. Professionals should employ a structured diagnostic process that begins with a thorough history and physical examination, followed by targeted investigations including imaging, chest X-ray, CT scan, laboratory tests, blood gases, inflammatory markers, cardiac biomarkers, and potentially invasive monitoring. This systematic approach allows for the differential diagnosis of acute respiratory failure, guiding the selection of appropriate interventions based on the identified pathophysiology, thereby ensuring optimal patient care within the ACCS domain. Question 19. Analysis of a recent audit revealing an increase in ventilator-associated pneumonia (VAP) rates within the adult critical care specialist (ACCS) unit, exceeding the established internal benchmark and national averages, prompts the need for a quality improvement initiative. Which of the following approaches best aligns with regulatory expectations for performance improvement and patient safety in this context? Option A. Initiate a comprehensive root cause analysis (RCA) to identify systemic factors contributing to the VAP increase, followed by the development and implementation of targeted interventions using a Plan Do Study Act (PDSA) cycle, informed by evidence-based practice and relevant clinical guidelines. Option B. Revise the unit's VAP prevention protocol based on a single, recently published high-impact study, without conducting an internal assessment of current practices or patient population specificities. Option C. Immediately implement a mandatory, unit-wide retraining program for all clinical staff on existing VAP prevention bundles, assuming current protocols are not being followed. Option D. Focus solely on comparing the unit's VAP rates with those of other high-performing ICUs nationally to identify best practices, without an internal investigation into the unit's specific performance drivers. The correct answer is A. Initiate a comprehensive root cause analysis (RCA) to identify systemic factors contributing to the VAP increase, followed by the development and implementation of targeted interventions using a Plan Do Study Act (PDSA) cycle, informed by evidence-based practice and relevant clinical guidelines. Explanation. This scenario presents a common challenge in adult critical care, balancing the implementation of evidence-based practices with the practical realities of resource allocation and staff engagement. The professional challenge lies in identifying the most effective and compliant method for improving a critical patient safety metric, ventilator-associated pneumonia (VAP) rates, within the constraints of a busy intensive care unit. Careful judgment is required to select an approach that is not only scientifically sound, but also ethically defensible and aligned with regulatory expectations for quality improvement. The correct approach involves a structured, data-driven methodology like a Plan Do Study Act (PDSA) cycle, integrated with a thorough root cause analysis (RCA) when VAP rates exceed established benchmarks. This aligns with the principles of continuous quality improvement mandated by regulatory bodies and professional standards. An RCA systematically investigates the underlying causes of a problem, moving beyond superficial symptoms to identify systemic issues. A PDSA cycle then allows for the iterative testing and refinement of interventions designed to address these root causes. This approach is ethically sound as it prioritizes patient safety by seeking to prevent harm and is regulatory compliant, as it demonstrates a commitment to evidence-based practice and performance improvement, as expected by accrediting bodies and professional organizations overseeing critical care. An incorrect approach would be to implement a new protocol based solely on anecdotal evidence or a single published study, without a systematic evaluation of its applicability to the specific unit's patient population and workflow. This fails to meet the standard of evidence-based practice, which requires critical appraisal and contextualization of research findings. Ethically, it risks introducing an ineffective or even harmful intervention. Regulatory failure occurs because it does not demonstrate a robust quality improvement process. Another incorrect approach would be to focus solely on staff education regarding existing VAP prevention bundles, without first conducting an RCA to understand why current practices may not be consistently followed or effective. While education is important, it is often a symptom management strategy if the underlying systemic barriers are not addressed. This approach neglects the deeper analysis required for sustainable improvement and may not satisfy regulatory expectations for comprehensive quality initiatives. A further incorrect approach would be to solely rely on national benchmarking data to drive changes without an internal investigation into the unit's specific performance. Benchmarking provides valuable context, but it does not explain the reasons for deviations from the norm within a particular unit. Without an internal RCA, interventions may be misdirected, leading to wasted resources and continued suboptimal outcomes, which is a failure in both quality improvement methodology and professional accountability. The professional decision-making process for similar situations should begin with clearly defining the problem and establishing baseline performance metrics. This should be followed by a systematic investigation, ideally an RCA, to identify contributing factors. Once root causes are understood, evidence-based interventions should be selected and piloted using a structured improvement methodology like PDSA. Continuous monitoring of outcomes and adaptation of strategies are crucial for sustained success and regulatory compliance. Question 20. Strategic planning requires a comprehensive understanding of respiratory physiology in critical illness to optimize patient outcomes. When managing a mechanically ventilated adult patient with acute respiratory distress syndrome (ARDS), which of the following approaches best reflects adherence to established ACCS principles for managing gas exchange and ventilation? Option A. Rapidly decreasing PEEP to minimize the work of breathing and facilitate early extubation, even if it compromises oxygenation. Option B. Adjusting positive end expiratory pressure (PEEP) to achieve a target PaO2 between 55-80 mmHg while maintaining lung protective tidal volumes and ensuring adequate carbon dioxide clearance. Option C. Increasing tidal volume to improve carbon dioxide removal, even if it exceeds lung protective limits, to prevent respiratory acidosis. Option D. Increasing the fraction of inspired oxygen, FiO2, to the maximum setting to ensure complete oxygen saturation, regardless of the PEEP level or tidal volume. The correct answer is B. Adjusting positive end expiratory pressure, PEEP, to achieve a target PaO2 between 55-80 mmHg while maintaining lung protective tidal volumes and ensuring adequate carbon dioxide clearance. Explanation. This scenario is professionally challenging because it requires the ACCS to balance immediate patient needs with the long-term implications of therapeutic interventions, all within the strict confines of established clinical guidelines and regulatory frameworks. The core of the challenge lies in interpreting complex physiological data and applying evidence-based practices to optimize gas exchange and ventilation in a critically ill patient, while also considering the potential for iatrogenic harm. Careful judgment is required to select the most appropriate ventilatory strategy that supports adequate oxygenation and carbon dioxide removal without exacerbating lung injury or compromising hemodynamic stability. The correct approach involves a systematic assessment of the patient's respiratory status, focusing on objective measures of gas exchange, PaO2, PaCO2, SaO2, ventilation tidal volume, respiratory rate, minute ventilation, and the mechanics of breathing, lung compliance, airway resistance. This assessment should then inform the selection of ventilatory settings that promote lung protective strategies, such as low tidal volumes and appropriate positive and expiratory pressure, PEEP, as guided by current ACCS best practice guidelines and relevant professional standards. The rationale for this approach is rooted in the principle of evidence-based medicine and the ethical obligation to provide the highest standard of care. Regulatory frameworks for ACCS emphasize the importance of adhering to established protocols and guidelines to ensure patient safety and optimize outcomes in critical care settings. An incorrect approach that focuses solely on achieving a specific PaO2 target without considering the underlying physiological derangements or the mechanics of breathing would be professionally unacceptable. This failure to conduct a comprehensive assessment and to apply a holistic understanding of respiratory physiology could lead to inappropriate ventilator settings, potentially causing barotrauma, volatrauma, or worsening V/Q mismatch, thereby failing to meet the ACCS duty of care. Another incorrect approach that prioritizes rapid weaning from mechanical ventilation without adequate physiological readiness, as evidenced by persistent respiratory muscle weakness or inadequate gas exchange, would also be a significant ethical and regulatory failure. This could result in reintubation and increased morbidity, contravening the ACCS responsibility to ensure patient stability and recovery. A third incorrect approach that involves adjusting ventilator settings based on subjective patient comfort alone, without objective physiological data, disregards the critical need for data-driven decision-making in critical care. This approach fails to acknowledge the complex interplay of factors influencing respiratory function in critically ill patients and could lead to suboptimal or harmful interventions. The professional decision-making process for similar situations should involve a structured approach. First, a thorough physiological assessment. Second, a review of current evidence-based guidelines and institutional protocols. Third, selection of an intervention that addresses the identified physiological derangements while minimizing potential harm. And finally, continuous reassessment and adjustment of the intervention based on ongoing monitoring of the patient's response. This iterative process ensures that care is tailored to the individual patient's evolving needs and remains aligned with the highest professional and regulatory standards.